Welcome back to the deep dive. Today we are really undertaking an intensive professional masterclass. This isn't just a survey. This is about, well, achieving mastery over some of the most high-risk scenarios in obstetrics.
Yeah, the really challenging ones.
Exactly. Specifically, multiple gestation, disorders of the amniotic fluid, and critical placental anomalies. Our goal is to synthesize the detailed pathophysiology, diagnostic markers, and, frankly, the non-negotiable management protocols needed for truly elite clinical practice.
That's precisely right. We're diving deep into sources that detail, the simultaneous development of fetuses, that fragile fluid environment they inhabit,
Right.
and that complex lifeline, the placenta and cord that connects them. For you, the listener, whether you're prepping for a high-stakes exam or just aiming for that professional mastery, we want absolute clarity on zygosity, chorionicity,
Crucial distinction.
the specific life-threatening complications unique to these conditions, and why really every protocol we discuss is potentially a matter of life and death.
Okay, let's unpack this immediately. Our foundation begins with the definition of multiple pregnancy, the simultaneous development of 2 or more fetuses in utero. While twins are the most common, the math of higher-order multiples really offers a stark reminder of their rarity.
Yeah, we rely on Helen's rules, established way back in 1895, to understand the natural mathematical frequency. So while twins are, relatively speaking, common, the incidence of triplets drops dramatically to roughly 1 in 80 squared pregnancies,
Wow.
and quadruplets fall to 1 in 80 cubed. It really provides the baseline for natural conception rates, highlighting just how unusual it is for nature to produce, say, 3 or 4 simultaneous implantations.
What we learn from the global data is fascinating because it tells us which factors might be biological versus maybe environmental. The natural incidence varies hugely. We see the highest rate in Nigeria, maybe 1 in 20 pregnancies, but it drops dramatically to 1 in 200 in Far Eastern countries. India falls somewhere in that intermediate range, around 1 in 80.
Right, and that variation from 1 in 20 to 1 in 200 is critical because it reflects the difference between the 2 types of twins. However, in the last few decades, the overall actual incidence of multiple pregnancy has shot up significantly, primarily driven by, well, professional intervention.
Ah, the treatments.
Exactly. This artificial increase is almost entirely due to the rising use of assisted reproductive techniques, or RTs,
Right.
and induction of ovulation drugs, things like gonadotropins and clomiphene citrate.
And when you look at gonadotropin therapy, for example, the sources indicate that this can lead to multiple fetuses in a staggering 20 to 40% of cases.
Yeah, it's huge.
Which means modern practice has basically created an entirely new risk profile that practitioners simply have to manage, separate from those background natural rates.
Which brings us right to the core distinction that dictates, well, everything about risk and management. Zygosity versus chorionicity. Zygosity is about the genetic origin. Chorionicity is all about the placental architecture.
Okay, let's start with the genetics then. Dizygotic, or DZ, twins. Those are the fraternal or binomial type.
Yeah.
They make up the majority, around 80%.
Right.
They're the result of 2 separate ova, fertilized by 2 separate sperms. Genetically, they're no more alike than any other siblings born years apart.
Yeah, just siblings who happen to share a womb.
Exactly. And the fluctuation in DZ twin rates is what drives that geographic variation we just mentioned, linked to factors like race, maternal age peaking between 30 and 35 heredity, and parity.
Then we have monozygotic, or MZ twins, the identical twins, making up about 20%. They result from the cleavage, the splitting, of a single fertilized ovum.
Okay.
And interestingly, the prevalence of MZ twinning is pretty constant globally, which suggests it's, I suppose, purely a function of the maternal environment somehow affecting that initial cleavage process.
Now let's pivot entirely to chorionicity because this is the information the obstetrician absolutely needs and needs early. Chorionicity is defined by the placenta and membrane status. And crucially, in MZ twins, it's determined by the timing of the cleavage of that single fertilized ovum. The progression of risk literally follows this timeline.
Yeah, this table of cleavage timing, it's non-negotiable for understanding risk. So the earliest cleavage, happening in less than 72 hours post-fertilization, results in diamniotic, dichorionic, or DD twins.
DD, got it.
This is about 25 to 30% of MC twins. Because the split happens so early, before the chorion has really formed, they essentially act like DZ twins in terms of membrane structure. Each has its own separate set of membranes, and usually its own placenta or a fused one. This is definitely the lowest risk category for MZ twins.
Okay, lowest risk, early split. What's next?
Moving to the largest group, If the cleavage occurs between days 4 and 7, we get the classic diamniotic monochorionic, or DM twins. That's 70 to 75% of MZ cases.
So most identical twins.
Yes. They share a single chorion and usually a single placenta, but they still maintain separate amniotic sacs. And it's the shared placental circulation that introduces the major risk of twin transfusion syndrome, or TTTS, which we'll definitely dig into later.
Right, the shared plumbing becomes the problem.
Exactly.
Yeah.
Now, the risk escalates dramatically with the third timeline, cleavage between days 8 and 12. This results in monoamniotic monochorionic, or twins, very rare, only 1 to 2% of MZ twins.
Sharing everything.
Sharing everything, the placenta, the chorion, and the amnion, they're in the same sac. This is considered probably the highest risk group in all of obstetrics, mainly due to the almost inevitable cord entanglement.
Okay, that sounds incredibly dangerous.
It is. And finally, the rarest and most problematic cleavage occurs after day 13, less than 1% of the time, resulting in conjoined or Siamese twins, where the division just isn't complete.
Wow. So what really stands out to me is that the entire clinical course, the entire risk profile of an MZ pregnancy, is dictated by just a 12-day window of embryonic development. It's incredible. Hashtag 1.3 methods for determining zygosity and chorionicity.
Absolutely. And given that chorionicity defines the risk, determining it accurately and early is, well, paramount. Diagnosis often begins simply if you see different fetal genders on ultrasound.
Then they have to be DZ.
Easy. Has to be dizygotic. If they're the same sex, then we must investigate chorionicity.
Okay, so how do we do that definitively?
The gold standard for risk assessment is transvaginal sonography, or TVS, ideally done in the first trimester, between 11 and 14 weeks.
Why that window specifically?
That window is optimal because the chorionic membrane layers are still distinct and visible. Later on, they can become compressed and harder to differentiate.
Makes sense. So what are we looking for on the scan?
We look for specific architectural signs. For dichorionic twins, the DD type, you need a thick septum, meaning greater than 2 millimeters, separating the sacs.
Thick septum.
More critically, you look for the lambda sign, or the twin peak sign. It looks like a triangular projection of placental tissue, specifically chorionic villi, extending right into the base of the membrane where it meets the uterine wall.
Like a little mountain peak.
Exactly. Since the chorion is the outer fetal membrane, seeing those villi extending like a wedge confirms there are two separate chorions, hence dichorionic. Safe-ish.
Okay, lambda or twin peak means dichorionic. What about monochorionic?
Conversely, if you see monochorionic twins, the DM type, the dividing membrane will be thin, less than 2 millimeters, and you'll see the T sign.
T sign.
Yeah, it visually represents the junction where the thin, two-layered amniotic membrane meets the shared placenta at basically a right angle. Looks like a T. Why is it thin? Because the chorionic layer, the main supporting layer, is shared and doesn't extend into the septum.
Ah, so the septum is just two amnions stuck together.
Exactly, just 2 layers of amnion, one from each sac, rather than the 4 distinct layers, amnion, chorion, amnion, that you'd find in dichorionic twins. It's a critical visual distinction.
So T sign, thin membrane, means monochorionic, higher risk.
Got it.
What about after delivery? Can we tell then?
Yes, absolutely. Examining the placenta and membranes after delivery is essential confirmation. For dizygotic placentae, you'll have 2 separate circulation systems. Crucially, the sources confirm there is no vascular anastomosis between the fetal vessels, even if the placentae look fused.
No shared blood flow.
None. And the intervening membrane will have those 4 layers if you examine it microscopically. For monozygotic twins, you usually find a single placenta with varying degrees of free vascular anastomosis.
Close connections.
Those connections are key. And the intervening membrane is either that thin, 2-layered amnion only in DM cases or completely absent in the very high-risk MM cases.
Okay. And if there's still doubt, say, same-sex DD twins.
For absolute definitive proof of zygosity, especially in those cases, you need genetic testing. The DNA microprobe technique is considered the most conclusive. And just as a fascinating historical note, the sources mention that the acceptance of a reciprocal skin graft between 2 individuals is considered almost certain proof of monozygosity. Reflects that shared genetic identity.
Huh. Wouldn't try that today, I imagine.
Probably not standard procedure, no. Hashtag 1.4 etiology and rare variations in twinning.
Okay, so we established that the MZ twin rate is stable globally, maybe driven by environmental factors affecting that initial split. But the DZ fluctuation is what generates that wide incidence variation we talked about.
Yeah.
Just to recap, DZ variation is strongly linked to race highest in people of African descent, lowest in East Asians.
Right.
Heredity, especially passed down through the maternal line. A mother's more likely to hyperovulate if her own mother did.
Makes sense.
And advancing maternal age, with that peak around 30 to 35.
And the sources describe some truly rare and frankly compelling variations in twinning. First, there's superfecundation.
Superfecundation. Sounds complex.
It just means the fertilization of two ovos released in the same cycle, but by separate acts of coitus within a short time frame, so potentially different fathers. Rare, but biologically possible.
Wow. Yeah.
Even more unusual and largely theoretical in humans is superfetation. This is where two ovos are fertilized in different menstrual cycles.
So getting pregnant while already pregnant.
Essentially, yes. One conception occurs after the first one is already established. The sources state this is theoretically only possible until about the 12th week, when the decidual space is obliterated and the uterine lining becomes non-receptive to a second implantation. Extremely rare if it happens at all in humans.
Okay, that's wild. What about things we see more often now with ultrasound?
Right. We often encounter the phenomenon of the vanishing twin thanks to early ultrasound. If one twin dies very early, within the first 14 weeks or so, the body often simply resorbs it.
It disappears.
Yeah, pregnancy just continues as a singleton. This rate of disappearance can be as high as 40% in twin pregnancies detected very early on.
40%? That's huge.
It is. Now, if the fetal demise occurs later, say in the second trimester, the dead fetus doesn't just disappear. Instead, it gets flattened and mummified between the membranes and the uterine wall. This is morbidly called fetus papyraceous or fetus compressus.
Papyraceous, like paper.
Exactly, flattened like parchment. This finding is more common in monozygotic twins. Seeing it on sonography or at delivery is quite striking. It really reinforces the power of the uterus to sort of contain a fetal demise.
Okay. And one more really unusual one.
Yes, fetus cardiacus, an abnormality seen exclusively in MZ twins. One fetus develops without a functioning heart, or often a head. It's essentially parasitic.
No heart. How does it survive?
It receives used deoxygenated blood from the normal co-twin via those placental anastomoses we talked about. This cardiac twin is amorphous, just a mass of tissue kept alive by the other twin circulation. And this, unfortunately, sets the stage for some really severe high-risk complications.
Okay, so moving into the clinical picture of carrying twins, it seems like it results in an exaggeration of nearly all the normal physiological changes of pregnancy.
That's exactly right. The mother's plasma volume increases by an additional 500 milliliters over a singleton pregnancy. That's a massive increase.
Half a liter extra.
Yeah, which leads directly to exaggerated hemodilution and consequently anemia. We also see significantly increased weight gain, much higher cardiac output, increased tidal volume in the lungs, and a higher glomerular filtration rate in the kidneys. Everything is working harder.
And the symptoms must be pretty intense then.
Oh, they're often debilitating, stemming from these exaggerations and just the sheer physical pressure. Profound nausea and vomiting are common. Cardiorespiratory embarrassment, things like palpitations, shortness of breath as the huge uterus pushes up on the diaphragm.
Barely breathe.
Right. And severe swelling, varicose veins, hemorrhoids. It's tough.
Clinically, what are the big red flags for the practitioner?
Well, the prevalence of preeclampsia is about 25%. That's 3 times higher than in singleton pregnancies.
3 times.
The theory is it's driven by the sheer superabundance of chorionic villi from the larger placental mass, which triggers that systemic inflammatory response characteristic of preeclampsia.
Okay, more placenta, more trigger.
Seems to be the link. On examination, the uterus takes on a distinctive barrel shape rather than the typical elongated singleton shape. The fundal height and abdominal girth often significantly exceed what you'd expect for the period of amenorrhea. Girth often goes over 100 centimeters at term.
So bigger than dates is a major clue.
A classic sign. Diagnostically, careful abdominal palpation should reveal an unusual number of fetal parts. Too many poles, or maybe feeling 3 poles or 2 distinct heads. That often makes the diagnosis almost certain even before imaging.
And listening for heartbeats.
Auscultation is trickier. You really have to detect 2 distinct fetal heart sounds, or FHS, at separate locations.
Right.
With a clear difference of at least 10 beats per minute between them and a silent area in between to be reasonably sure you're hearing 2 separate hearts beating simultaneously.
Okay, what about how the babies are positioned? Lie and presentation.
Well, about 90% are longitudinal, which is good. But malpresentations are highly common. We have to be prepared for various combinations. Both vertex head down is most common, about 50%.
Oh,
Then you get vertex breach in about 30%, breach vertex in 10%, and both breach in another 10%. The rarest, and one you really need to note, is both transverse. If you see that, you must immediately rule out conjoined twins, hashtag tag tag 2.2 major fetal complications, and the monochorionic risk.
okay, let's talk about the stark risks to the fetuses themselves. The sources are pretty clear on this.
Yeah, the chances of miscarriage are significantly higher. Preterm birth is almost the expectation rather than the exception occurs in maybe 80% of twin pregnancies. The mean gestational age at delivery is around 37 weeks, not 40.
So term, but just barely.
Right. They also face low birth weight, naturally, and about a 2 to 4% increase in fetal anomalies overall, again, most pronounced in the MC twins.
And what about growth? Do they grow equally?
Not always. Discordant growth is a major challenge, affecting about 20% of twins. True pathological discordance is strictly defined by the sources as an estimated fetal weight difference of 25% or more between the twins.
25%. Why does that happen?
Could be several reasons. Simple placental insufficiency, where one twin just gets a smaller share of the placental territory. It could be structural anomalies in just one twin, limiting its growth. Or, most notoriously, in monochorionic twins, it's a sign of that twin-twin transfusion syndrome.
Okay. And what happens if one twin dies later in the pregnancy?
That's a really serious situation, carrying a profoundly high risk to the co-twin, particularly in monochorionic pregnancies.
Because of the shared circulation again?
Exactly. The presence of those vascular anastomoses is the conduit for danger. When one twin dies, thromboplastin and other vasoactive substances are released from the dead fetus. These cross the anastomoses into the living twin's circulation, potentially causing widespread ischemia, like tiny clots.
Leading to...
It can lead to the death of the co-twin, or severe neurological damage, things like cerebral palsy, microcephaly, or even renal cortical necrosis in up to 25% of the surviving monochorionic twins. A devastating outcome.
25% risk of major damage. Wow.
It's huge, and we absolutely cannot overlook the risks specifically to the second baby during the delivery process itself.
Higher risk for twin B.
Significantly. The sources confirm the second twin is at roughly 50% higher risk than the first.
Why is that?
Primarily due to the sudden reduction in uterine volume after the first birth. The uterus starts to retract quickly, which can lead to acute placental insufficiency for the remaining twin. Plus, there's often increased need for operative intervention like forceps or breech extraction, and a 5-fold higher risk of cord prolapse for that second twin.
5 times the risk of cord prolapse.
Yeah. So this brings us right back to that hierarchy of risk we touched on. Complications are definitely higher in MZ than DZ twins overall. And they are highest of all in those monoamniotic, monochorionic, the MM twins, mainly due to that complete lack of a dividing membrane and the almost unavoidable cord entanglement. Hashtag tag 2.3 life-threatening monochorionic complications.
Okay, let's dive into those specific life-threatening monochorionic complications. TTTS seems like the big one.
Twin transfusion syndrome, or TTTS, yes, it's the flagship complication here. It exclusively affects monozygotic twins who share a chorion, so DM or MM, impacting about 10 to 15% of them.
And it's caused by?
It's caused by the presence of deep unidirectional arteriovenous anastomoses within that shared placenta. Think of them as one-way streets for blood flow. This creates a profound hemodynamic imbalance between the twins.
An imbalance. How does that manifest?
It's stark. The donor twin is chronically losing blood volume, so it becomes smaller, develops oligohydramnios, very little amniotic fluid, often appearing pinned against the uterine wall, giving that stuck twin appearance. They are anemic, hypotensive, and hypovolemic.
Okay, the donor is grained. What about the recipient?
The recipient twin is getting overloaded with all that extra blood. So they become larger, develop severe polyhydramnios, way too much amniotic fluid, become polycythemic, thick blood, hypertensive, and hypervolemic. They are at very high risk of congestive cardiac failure and hydrops fetalis, which is massive fluid overload and swelling.
It's a mirror image pathology almost.
It is. Diagnosis requires precise criteria on ultrasound and Doppler. You need to see that difference in fluid volumes, but also confirm a difference in hemoglobin of at least 5 grams percent between the twins if you can sample, and that critical weight discrepancy of 25% or more.
In the prognosis.
Grim without intervention. Perinatal Perinatal mortality approaches 80%, especially with early onset before mid-gestation. Management is highly specialized and urgent. The gold standard now is fetoscopic laser photocoagulation. Yes, using a laser to go in and seal off or coagulate those specific pathological anastomoses causing the transfusion. Less aggressive treatments, sometimes used as temporizing measures, include repeated amniocentesis to drain the excess fluid from the recipient twin sac, relieving pressure, or in extreme, often later cases, selective reduction might be considered.
Okay, laser is the main treatment. What else is specific to monochorionic?
Another devastating condition is the twin reversed arterial perfusion sequence, or TRP. This links directly back to that cardiac twin we mentioned earlier.
One with no heart.
Exactly. In TRP, the cardiac twin receives used, deoxygenated blood directly from the normal co-twin via large artery-to-artery anastomosis on the placental surface. The normal, healthy twin becomes the circulatory pump, or donor, working double time to supply this parasitic mass.
That sounds incredibly stressful for the healthy twin.
It is. This constant demand leads to high output cardiac failure in the donor twin, resulting in very high perinatal mortality for the otherwise healthy twin.
How do you manage TRP?
Management for TIP focuses on stopping that circulatory drain. Usually this involves techniques like cord ablation or ligation of the cardiac twin's umbilical cord, often done fetoscopically early in the pregnancy, to save the normal twin.
Then there are the twins, that rare 1% to 2% group.
Right. Since they share the same amniotic cavity, their umbilical cords are constantly moving around each other. This leads almost inevitably to cord entanglement.
Just tangled up.
Yeah. This is a constant, essentially unmanageable risk throughout the entire pregnancy. It causes very high perinatal mortality rates simply due to acute cord compression and sudden cutoff of blood supply. Management often involves very early delivery, often preterm, once viability is reached.
Okay, is extremely high risk due to cords.
Yeah.
And finally,
conjoined twins. The fusion after day 13 results in specific types based on where they're joined. Thoracopagus, joined at the chest, is the most common.
thorax, chest, makes sense.
Others include pyopagus, joined at the sacrum, craniopagus, head, ischiapagus, pelvis, even rhachypagus, spine. The absolute key to survival, and thus the potential ability to surgically separate them after birth, depends entirely on the degree of organ sharing. Particularly, any major cardiovascular connection is often the deciding factor. Hashtag tag 2.4 antenatal management in labor protocols.
All right, so switching gears to antenatal management, it sounds like it demands extreme vigilance, starting with that early diagnosis and nailing down the chorionicity.
Absolutely critical. Advice starts with nutritional specifics. The sources recommend an extra 300 kilocalories per day over a singleton diet. Increased iron is vital, 100 to 200 milligrams per day due to that hemodilution. And specific folic acid supplementation, 5 milligrams daily, not the standard dose, plus extra calcium.
And rest.
Increased rest is definitely advised, particularly from 24 weeks onward, really to try and maximize uteroplacental circulation.
Okay, and the surveillance schedule. Sounds intense.
It is rigorous. Serial sonography is performed, say, every 3 to 4 weeks for the lower-risk dichorionic twins, mainly monitoring growth. But for the high-risk monochorionic twins,
The DM and MM ones.
yes, the sources mandate surveillance every 2 weeks. This frequency is needed to detect the very earliest signs of TTTS, developing growth restriction or amniotic fluid imbalances. You have to catch it early.
Every 2 weeks. Wow. Now, while intervention is key, it's also important to note what not to do, right?
Yes, good point.
Yeah.
Routine prophylactic use of things like tocolytics drugs to stop contractions or progesterone supplementation, or even putting in a cervical cerclage, has shown no measurable benefit in preventing preterm delivery in uncomplicated twin pregnancies.
So those common preterm prevention strategies don't work for twins.
Not routinely, no. However, corticosteroids, betamethasone or dexamethasone, are definitely given if preterm labor is anticipated before 34 weeks to help mature the fetal lungs. And interestingly, the sources note that twins tend to develop pulmonary maturity maybe 3 to 4 weeks earlier than singletons anyway.
Okay. Now let's talk about the delivery itself. High-risk protocol needed.
Absolutely. Delivery of multiples is a high-risk event that must take place in a fully equipped hospital with immediate access to an intensive neonatal care unit, or NICU.
Makes sense. What about preparation during the first stage of labor?
Preparation is key. You need a skilled team, an experienced obstetrician, and an anesthetist must be present throughout. Ultrasound must be readily available right there in the labor ward. The patient needs to be confined to bed, largely to prevent early cord prolapse if the membranes rupture unexpectedly.
Right.
An IV line must be in place, and cross-matched blood must be readily available because of the PPH risk we'll discuss. And ideally, 2 neonatologists or pediatric teams should be present, one ready for each baby.
2 baby teams. Got it.
Okay.
What about membrane rupture?
This is critical, non-negotiable. Immediately after rupture of the membranes, whether spontaneous or artificial, an internal vaginal examination must be performed
Why me?
to definitively exclude cord prolapse. Remember, that risk is 5 times higher for the second twin and can happen even with the first. You have to check right away. Epidural analgesia is generally preferred because it provides excellent pain relief, but also facilitates any necessary quick fetal manipulation later on, like an internal version, without needing sudden general anesthesia.
Okay. Delivery of the first baby.
Yeah.
I think special there.
Yes, a vital safety measure. The umbilical cord of the first twin must be clamped securely in 2 places and cut in between.
2 clamps. Why?
To prevent the potential sudden exsanguination or bleeding out of the second twin through those shared placental circulations if it's a monochorionic pregnancy. If they share vessels, clamping just once could let the second twin bleed back through the placenta and the first cord.
Okay, that's crucial.
Absolutely. Also, intravenous ergometrin, a drug to contract the uterus, is strictly avoided at this stage. We need the uterus to stay relatively relaxed to allow for the safe maneuvering and delivery of the second twin.
Right, don't clamp down the uterus yet. So twin 1 is out. What about twin 2?
Expedition is the guiding principle for the second twin. The interval between deliveries should ideally be less than 30 minutes. Any longer, and risks start to increase.
So act fast. What's the first step?
As soon as the first twin is delivered, the lie, presentation, and fetal heart sounds, the FHS, of the second twin must be confirmed immediately, usually with that ultrasound right there in the room.
Okay, find out where twin 2 is and how it's doing. Then what?
If the second twin is longitudinal, either vertex or breech, we perform a low rupture of the membranes, or amniotomy, carefully ensuring the presenting part is fixed over the pelvic inlet first to prevent cord prolapse. Oxytocin infusion is often started or increased if contractions are poor.
And if there's a delay, more than 30 minutes?
If there's a delay exceeding 30 minutes, or if any signs of fetal distress appear on monitoring, immediate interference is required. This might mean forceps or vacuum for a vertex presentation or a breech extraction.
What if the second twin is transverse, lying sideways?
If it's transverse, the first attempt is usually external cephalic version trying to turn the baby from the outside. If that fails,
Then what?
then internal pedalic version under general anesthesia is required. This is where the obstetrician reaches inside the uterus, grabs the baby's feet, and pulls it down into a breech presentation for extraction. The sources are definitive here. This specific scenario, a transverse second twin with failed external version, is pretty much the only accepted indication for internal version in modern obstetrics because of the significant risks involved for both mother and baby.
Wow, okay, a very specific, rare maneuver. Now, both babies are out. Is the danger over?
Not at all. Following all this, the final and arguably the most dangerous challenge is the third stage of labor, the risk of postpartum hemorrhage, or PPH.
Why is the PPH risk so high?
The risk is profound. It's primarily due to massive uterine atony, the inability of the uterus to contract down effectively simply because it was so overdistended by 2 babies, placentas, and fluid. Also, the placental separation can take longer, and the sheer surface area of the implantation site is much larger, leading to more potential bleeding.
So what's the protocol?
Active management of the third stage is mandatory and aggressive. This involves routine administration of a uterotonic drug, usually of 0.2 milligrams of methogen intravenously, or 10 international units, IU, of oxytocin intramuscularly immediately following the delivery of the second baby. This is followed by a continuous intravenous oxytocin drip for at least 1 hour, sometimes longer, to ensure the uterus contracts down firmly and stays contracted.
Okay, active management is key. When would a cesarean section be planned from the start?
A cesarean section is generally indicated if the first twin is noncephalic, so breech or transverse. Also for twins with major complications identified antenatally, like severe intrauterine growth restriction, IUGR, known conjoined twins, all twins because of the cord risk, or sometimes severe TTTS. Another indication is if the fetal heads collide or get stuck at the pelvic brim, a serious complication known as interlocking.
Interlocking. That sounds bad.
It is. This is usually when the aftercoming head of the first twin in a breech delivery gets locked with the forecoming head of the second twin, usually vertex. It's a true obstetric emergency requiring immediate skilled vaginal manipulation or, more often, an emergency caesarean section. In truly desperate scenarios, if twin 1 has already died during this process, decapitation of the dead twin might even be required as a last resort to save twin 2.
Okay, let's shift our focus now to the fluid environment itself, starting with too much fluid. Polyhydramnios, sometimes called hydramnios.
Right. Anatomically, this just means the volume of liquor amni exceeds 2,000 milliliters, so 2 liters. But clinically, we rely on sonographic diagnosis using precise metrics. The amniotic fluid index, or AFI, needs to be greater than 24 centimeters.
AFI over 24.
Or the single deepest vertical pocket, or DVP, must measure more than 8 centimeters.
DVP over 8. Got it. What causes this excess fluid?
Well, the etiology actually reveals critical information about fetal function and swallowing, while a large chunk, maybe 60% of cases, remain idiopathic, meaning we don't find a specific cause.
Okay.
The known causes, that other 40%, link directly to fluid dynamics, specifically either failure of fetal swallowing or absorption or excessive fetal urination.
Like what?
Fetal anomalies account for about 20% of known causes. An encephaly absence of the brain and skull is associated with hydramnios in a massive 50% of cases.
50% with an encephaly. What?
Thought to be due to two things: transudation of fluid from the exposed meninges and also the lack of a proper fetal swallowing reflex. Also, any blockage in the upper gastrointestinal tract, like esophageal or duodenal atresia, physically prevents the fetus from swallowing and absorbing the amniotic fluid it produces through urination.
So if they can't swallow it, it builds up.
Exactly. Maternal conditions also play a significant role. Maternal diabetes is associated with about 30% of polyhydramnios cases.
Diabetes, how does that cause it?
The underlying mechanism is pretty clear. High maternal blood sugar crosses the placenta, leading to high fetal blood sugar. This acts as an osmotic diuretic in the fetus, causing excessive fetal urination, a fetal diuresis, which simply overwhelms the normal fluid balance mechanisms, leading to the hydramnios.
Fetal pee overload, essentially.
Pretty much. And of course, multiple pregnancies themselves are about 10 times more likely to have hydramnios, often specifically affecting the recipient twin sac in TTTS due to that volume overload.
Okay. Clinically, how does polyhydramnios present?
Clinically, it can be chronic, which is the most common form, developing insidiously over weeks. Or, much more rarely, it can be acute with very sudden onset, usually before 20 weeks, often linked to severe TTTS or sometimes a placental tumor called a chorioangioma.
And the symptoms for the mother?
The symptoms are usually severe and purely mechanical from the sheer volume and pressure. Profound dyspnea, shortness of breath, often forcing the mother into a preferred sitting position just to breathe. Severe edema or swelling, especially in the legs and vulva. On examination, the abdomen is typically very tense and globular. A fluid thrill might be palpable in all directions. Fetal parts are often difficult or impossible to feel, and the fetal heart sound might only be audible with a Doppler device.
Sounds miserable. How is it managed, especially if severe?
Management in severe cases definitely requires hospitalization. The main principles are to relieve those severe maternal symptoms, try to find the underlying cause if possible, and proactively prevent complications like premature labor, accidental placental abruption, or cord prolapse when the membranes eventually rupture.
What therapies help?
Supportive therapy can include the use of Cilindac, which is a nonsteroidal anti-inflammatory drug, a COX-2 inhibitor given orally, maybe 200 milligrams every 12 hours. This can be effective in unexplained cases because it works by reducing fetal urine output. Diuretics given to the mother, however, are largely ineffective as the excess fluid is primarily contained within the amniotic sac, not in the mother's circulation.
Okay, Cilindac might help. What if symptoms are really bad?
For severe maternal distress, especially before 37 weeks, therapeutic amnioreduction via amniocentesis is essential. This means draining off the excess fluid.
Just drain it.
Yes, but crucially, the sources mandate slow decompression, no faster than 500 milliliters per hour.
Half a liter an hour, max. Why so slow?
This meticulous slow release is necessary to minimize the risk of sudden changes in uterine pressure that could precipitate placental abruption or cord prolapse. Drainage is usually stopped when the AFI drops below 25 centimeters or the symptoms are relieved. The procedure might need to be repeated if the fluid reaccumulates.
Okay. And if the patient is near term?
If the patient is past 37 weeks and the cervix is favorable, induction of labor is often the best course. This is typically done via a carefully controlled amniocentesis to drain a significant amount of liquor first, making the uterus less tense, followed by an oxytocin infusion to stimulate contractions once the fetal lie is stabilized and confirmed longitudinal. Hashtag 3.2 oligohydramnios, oligohydramnios.
All right, let's flip to the inverse condition. Oligohydramnios or oligoamnios. Too little fluid.
Right. This is defined as a severely deficient volume of liquor amnii, technically less than 200 milliliters at term. Sonographically, the criteria are a maximum vertical pocket, or MVP, same as DVP, measuring less than 2 centimeters, or an AFI less than 5 centimeters.
MVP less than 2, AFI less than 5. Got it.
Yeah.
What causes too little fluid?
The etiology here is usually tied to either reduced fetal urine production or problems with urine exit. Major fetal causes include severe structural anomalies like bilateral renal agenesis, where the kidneys don't develop at all, sometimes called Potter's syndrome, or some form of obstructed uropathy like posterior urethral valves, which physically prevent the fetus from creating or releasing urine into the amniotic sacs.
There's no fluid.
Essentially. Other common causes are severe uteroplacental insufficiency leading to intrauterine growth restriction, or IUGR. The growth-restricted fetus shunts blood away from its kidneys to preserve brain and heart function, reducing urine output. Post-maturity can also cause it, as placental function declines. Intrauterine infection, or the effects of specific drugs taken by the mother, like prostaglandin inhibitors and SAIDs, or ACE inhibitors for blood pressure, can also suppress fetal kidney function and cause oligohydramnios.
Okay, how does this present clinically?
Clinically, the uterine size is often smaller than expected for the gestational age. On palpation, the uterus feels almost rigidly full of fetus because there's so little cushioning fluid. Malpresentation, particularly breech, is highly common because the fetus simply cannot float and turn properly into the headbound position.
And the risks to the fetus sounds serious.
The fetal complications are severe and include high perinatal mortality. The lack of fluid causes profound compression deformities, things like clubfoot, talipes, wry neck, torticollis, or even limb amputations due to restrictive intra-amniotic adhesions forming.
Wow.
But the most critical, often life-limiting risk associated with severe early-onset oligohydramnios is fetal pulmonary hypoplasia.
Pulmonary hypoplasia,
Okay.
underdeveloped lungs.
Exactly. The fetal lungs require the physical presence, the hydrostatic pressure, and the volume of the amniotic fluid to properly stretch the developing alveoli and allow them to mature structurally. Without sufficient fluid for a prolonged period, the lungs simply fail to develop adequately. This often leads to catastrophic, lethal respiratory failure immediately after birth. Plus, during labor, cord compression is a constant, immediate threat because there's no fluid buffer.
Okay, pulmonary hypoplasia is the big killer here. How is oligohydramnios treated?
Management really depends on the underlying cause and the gestational age. If a major congenital malformation like renal agenesis is suspected, referral to a specialized fetal medicine unit is crucial for counseling and planning. For isolated oligohydramnios diagnosed later in the 3rd trimester, sometimes conservative management with aggressive maternal oral hydration, drinking lots of water, is attempted, as it can sometimes modestly increase the amniotic fluid volume.
Does drinking water really help?
Sometimes, to a small degree. But during labor, especially if there's evidence of cord compression on the fetal monitor or thick meconium staining of the fluid, amnioinfusion is often used.
Amnioinfusion, what's that?
That's where warm, sterile saline solution is infused directly into the uterine cavity through a catheter placed transcervically after the membranes have ruptured.
Why do that?
Amnioinfusion serves 2 main purposes. Therapeutically, it can help cushion the umbilical cord, reducing the frequency and severity of variable decelerations caused by cord compression. And prophylactically, especially if there's thick meconium, it helps dilute the meconium, potentially reducing the risk of meconium aspiration syndrome in the newborn. Studies have generally shown that its use can improve neonatal outcome in select cases by stabilizing that intrapartum environment.
Okay, final section. Let's move to the critical lifeline itself, the placenta and cord, starting with abnormalities in placental shape or morphology. These seem like they carry predictable, sometimes severe risks. First up, placenta sexcenturiata.
Right. This is found in about 3% of pregnancies. Sexcenturiate means accessory or extra. So it's where you have one or more small accessory placental lobes that are separate from the main placental disc.
Okay, like little extra islands of placenta.
Exactly. And they're connected to the main placenta only by fetal blood vessels that run unprotected through the membranes between the main disc and the accessory lobe.
Why is that significant?
The massive clinical significance arises if one of these accessory lobes is left behind, retained in the uterus after the main placenta is delivered.
Ah, it gets missed.
Precisely. Retention of a sexcentriate lobe can precipitate immediate primary postpartum hemorrhage or delayed secondary PPH weeks later. It can also lead to subinvolution of the uterus, where it doesn't shrink back properly, uterine sepsis or infection, and eventually chronic inflammation leading to polyp formation.
So how do you manage that?
Vigilance. If the obstetrician or midwife examines the delivered placenta and membranes and notices torn blood vessels running out to the edge of the membranes with no placental tissue attached, or if the placental disc itself looks incomplete, they must suspect a retained sexcentriate lobe. Immediate manual exploration of the uterine cavity and removal of the missing lobe is mandatory to prevent those complications.
Okay, check the placenta carefully. What's next? Placenta extracoriolis.
Yes, placenta extracoriolis is a broader term that includes the specific entity known as circumvallate placenta. Visually, what you see is that the chorionic plate, the shiny fetal side of the placenta, is smaller than the basal plate, the maternal side.
Smaller on top than on the bottom.
Right. This causes the membranes, the amnion and chorion, to fold back on themselves at the edge of the chorionic plate, creating a distinct, often thick, whitish ring on the fetal surface. This ring is composed of double folds of amnion and chorion, along with some degenerated decidua and fibrine deposits.
Does this abnormal shape cause problem?
Yes, this abnormal attachment is definitely not benign. It's associated with an increased chance of miscarriage, antepartum hemorrhage, bleeding before labor, intrauterine growth restriction, IUGR, and preterm delivery.
Okay.
It can also cause a specific condition called hydrea gravidarum.
Hydrea gravidarum.
Yeah, it literally means watery flow during pregnancy. It's thought to be caused by leakage of amniotic fluid or transudate from within those folded over membranous layers, leading to excessive, persistent watery vaginal discharge.
Okay. Any other weird placental shapes?
A few others mentioned. Placenta membranacea is one where the placenta is unduly large and very thin, spreading out like a membrane and covering practically the entire inner surface of the uterus.
Wow, covers everything.
Almost. The risks here are high rates of placenta previa because it's implanted so low and wide, significant PPH due to its large surface area and potentially poor contractility of the underlying uterus, and real difficulty with manual removal if it doesn't separate cleanly. Then there's placenta bilobata, basically two separate, roughly equally sized placental discs. The cord usually attaches either to a connecting bridge of chorionic tissue between them or sometimes just to the intervening membranes. This carries similar complications to placenta sexcentriata regarding the risk of retaining one of the lobes.
Makes sense. Have to get both parts out.
Exactly. And finally, a really unusual one is placenta fenestrata, where there's literally a hole or window missing in the central portion of the placental disc. The main risk here is misdiagnosis, thinking you have a retained cotyledon or fragment, when in fact the entire, albeit wholly, structure has been delivered. Hashtag 4.2 abnormalities of cord attachment and structure.
Okay, let's move from the placenta itself to the cord abnormalities of its attachment or structure. These seem like they can pose immediate threats, especially during labor. Let's start with battledore placenta.
Right. Battledore placenta just means a marginal cord insertion. Instead of inserting somewhere centrally on the placental disc, the umbilical cord attaches right at the very margin or edge.
Like the handle of a ping pong paddle. A battledore.
Exactly the analogy. Is it dangerous? Well, if this marginal attachment occurs alongside a low placental implantation near the cervix, it significantly increases the risk of cord compression during labor as the fetal head descends, potentially causing fetal distress or anoxia.
Okay, location matters. What's considered the most dangerous attachment abnormality?
That would definitely be velamentous placenta or velamentous cord insertion. Here, the umbilical cord doesn't insert directly into the placental mass at all. Instead, it inserts into the fetal membranes, the amnion and chorion, at some distance away from the placenta itself.
So it attaches to the sac, not the placenta.
Yes. And then the major umbilical arteries and vein have to travel, unprotected, branching out within the membranes for some distance before they actually reach the placental edge and dive in.
Unprotected vessels in the membranes. That sounds risky.
Extremely risky. The absolute obstetric emergency arises when these traversing, unprotected velamentous vessels happen to lie across the internal os, the opening of the cervix. This specific condition is known as vasa previa.
Vasa previa. Vessels in the way.
Precisely. The danger is immense because when the membranes rupture, either spontaneously or artificially, these fragile vessels are right there, totally exposed, and can easily tear as well, since this is purely fetal blood circulating in these vessels.
Fetal blood loss.
Yes, the consequence is rapid, massive fetal exsanguination, bleeding out, often leading to severe fetal compromise or death within minutes. Practitioners must try to recognize this risk prenatally, ideally using transvaginal ultrasound with color Doppler to visualize vessels near the cervix. If vasa previa is diagnosed before labor,
Then what?
management requires planned, urgent delivery, typically by elective caesarean section well before labor starts and the membranes rupture, to avoid catastrophe.
Okay, vasa previa is a true emergency. What about the cord structure itself, like its length?
Yes, abnormalities of cord length are also significant. A pathologically short cord, often defined as less than 20 centimeters, or even just relative shortness due to being wrapped tightly around the fetus. Nuchal cord, body cord.
Can cause problems.
Absolutely. It can cause failure of fetal descent during labor. The baby literally can't come down because it's tethered. It can also cause premature placental separation, abruption, as the descending fetus pulls hard on the short cord, or acute fetal distress from cord stretching and compression.
Okay, and too long.
Conversely, an excessively long cord, and they can be incredibly long, sometimes up to 300 centimeters, increases purely mechanical risks. There's a dramatically increased chance of cord prolapse when the membranes rupture, a higher likelihood of entanglement around the fetal neck or body, which can lead to compression and distress or even fetal death, and a higher incidence of true knots forming in the cord.
True knots. Can they tighten?
They can, but fortunately, true knots are often protected from causing complete occlusion by the copious amount of Wharton's jelly, that gelatinous substance surrounding the cord vessels. It usually prevents the knot from tightening down sufficiently to completely stop blood flow, but they still carry risk.
Okay, one last cord issue.
Yeah.
The number of vessels.
Right. Finally, we must note the single umbilical artery, sometimes called SUA or two-vessel cord. Normally, there are two arteries in one vein. SUA is present in about 1 to 2% of singleton pregnancies, but more common in twins and associated with maternal diabetes, oligohydramnios, and preeclampsia.
Why is finding just one artery important?
It's an important marker because it is associated with underlying congenital malformations in a significant portion, maybe 20 to 25% of affected fetuses. The anomalies most commonly involve the renal, kidney, and genital systems, but also cardiac defects and chromosomal issues, particularly trisomy 18.
So finding a single artery triggers a closer look.
Absolutely. Finding an SUA mandates a highly detailed fetal anatomical survey via ultrasound to search carefully for any coexisting structural problems. It also slightly increases the overall risk for uterine growth restriction and perinatal mortality, even if no other anomalies are found. #outro.
Wow. This deep dive has really demanded precision, hasn't it? Detailing all those non-negotiable criteria required for managing these high-risk pregnancies. From the exact cleavage timing defining twin risk to the specific indices for fluid disorders, AFI greater than 24 centimeters, DVP less than 2 centimeters, and those absolute visual markers on ultrasound like the lambda sign versus the T sign.
Yeah.
It really feels like achieving mastery here means knowing not just the diagnosis, but those precise thresholds that absolutely mandate intervention.
Absolutely. And I think we've established that the diagnosis of chorionicity in twins is probably the single most important prognostic factor. It dictates everything, the intensity of surveillance, shifting from maybe monthly scans to every 2 weeks for monochorionic.
Right.
And the entire labor protocol, including critical details like that 2-point cord clamping to protect the second twin. Furthermore, understanding the immense risk of postpartum hemorrhage in all multiple births and the immediate, potentially life-terminating danger of conditions like vasa previa. Well, it underscores exactly why these areas represent the apex of high-risk obstetrical practice.
And the necessity for such rapid, definitive action in many of these scenarios really highlights that complex ethical dilemmas are often inseparable from clinical practice.
Oh, absolutely. Think about it. We discussed the rationale for selective reduction in higher order multiples, like quadruplets or more, to improve the overall outcome by reducing the number of fetuses. Now, if we apply that complex principle to a dichorionic twin pair, remember, separate facts, separate placentas, lower risk overall, where maybe prenatal genetic testing reveals a relatively minor, non-lethal structural anomaly in just one fetus, intervention would likely require a procedure like selective termination of that affected fetus, which, while generally safe, still carries a small inherent risk of miscarriage or harm to the remaining healthy co-twin.
Right, no procedure is zero risk.
Exactly. So This raises a really profound clinical and ethical question. How should the professional mandate, the principle of maximizing overall fetal outcome, ethically guide the decision making? Do you intervene to fix the anomaly by terminating that fetus, thereby accepting a small risk to the healthy co-twin for what might be considered a mild benefit to the overall pregnancy outcome? Or do you simply wait, continue the pregnancy, and manage the known anomaly after birth? It's a conflict that relies heavily on accurate data and risk assessment, but ultimately it's resolved by a very difficult human choice made in partnership with the parents. Something to really think about.